Hello and welcome to the Future of Cancer Care in Massachusetts, hosted by the Boston Globe. My name is Jessica Bartlett. I'm a healthcare reporter for the Boston Globe, and I'm here to moderate our panel. I would like to first introduce our panelists. So we have Dr. Craig Bunnell, Chief Medical Officer for Dana-Farber Cancer Institute, Nakia Clark, Director of Patient Services and Outreach for the Ellie Fund, and Amy Brewer, President and CEO of Sturdy Health. Hello to you all. I'm hoping we could go through and just for each of you to introduce who you are, what your organization does, and how it kind of is involved in cancer care. Starting with Nakia, please.
Yes, thank you. Nakia Clark. I am the Director of Patient Services and Outreach at the Ellie Fund, and my organization provides services to anyone going through breast cancer treatment.
Excellent, thank you. Amy?
Hi, I'm Amy Brewer. I'm the President and CEO of Sturdy Health. We are a independent health system down in Attleboro, Mass. So we serve Southeastern Mass and part of Rhode Island. And we are a hospital and then 26 location outpatient primary care and specialty care. And we have a cancer center as well.
Excellent, thank you. And Craig?
Hi, I'm Craig Bunnell. I'm the Chief Medical Officer at the Dana-Farber Cancer Institute and a medical oncologist. The Dana-Farber is an NCI-designated comprehensive cancer center that's entirely focused and dedicated to providing expert compassionate care for children and adults with cancer, conducting research to advance the understanding, diagnosis, treatment, and prevention of cancer, and to training the next generation of cancer care providers and researchers.
Excellent. Well, thank you all for joining me today. I was hoping we could start just by table setting a bit, starting, Nakia, with you. What does it look like for someone to go through cancer treatment these days? And has that really changed from a decade or so ago, or is it pretty much the same from a patient perspective? Starting, everyone says this is all about the patient. So let's start with the patient. How is it like getting cancer care these days?
Yes, so it's a little different. I think it's advanced where for our organization we're able to provide and grow services that allows the patients to be able to get to their treatment. That is the focus, is making sure that they can get to their treatments and stay in their treatments. So there's lots and lots of organizations like mine who provide that service so that we can make sure that the patients get there and get exactly what they need.
And Craig, is cancer care largely outpatient these days? It seems to me that it's shifting from inpatient to outpatient care. But how has care evolved from where it's delivered and also what kind of treatments are happening? Set the stage for us in terms of a delivery and a medical perspective.
Sure. So I'll start with the sort of, advances in cancer care. So so I've been a medical oncologist for 30 years. The advances in that period of time have been extraordinary, and particularly really over the last 10 years, but just accelerating exponentially. We have a deeper understanding of the genetic and molecular basis of cancer, and through that have developed more personalized medicines for a patient's the mutations that cause a patient's particular type of cancer. We, based on discoveries at the Dana-Farber, we've developed drugs that prompt the immune system, that teach the immune system to recognize and fight cancer. And we've developed extraordinary treatments in recent years, cellular therapies, something called CAR-T, in which we remove a patient's immune cells and teach them how to recognize and fight the patient's cancer, and we reinfuse those and actually are able to cure patients who could have had weeks to live, and it's these sort of Lazarus-like treatments. In terms of how delivery of our treatment has changed over that period of time, I'd say that when I first began in my training and early years, we admitted most patients to the hospital for their routine cancer chemotherapy treatments because we were not very good at controlling the side effects of treatment, the nausea, the vomiting, the infections. And really over the next, over the first 20 years, we developed supportive care therapies to prevent and treat nausea and vomiting, to prevent infections. And cancer care really moved out of the hospital and largely into the ambulatory setting. And I think what's starting to happen now, that still continues to be the case for the vast majority of cancer treatments. Most of it is happening in the ambulatory setting. With some of these newer treatments, the CAR-T and cellular therapies, some of the specific antibody therapies, some of the side effects of our immune therapies, those really are requiring some shifting back into the hospital. And so while the majority of our treatments are still in the ambulatory setting, the newer and more complicated therapies really have moved back into the inpatient setting.
Interesting. And so, Amy, as cancer care evolves, I mean, Craig just went through this massive evolution of cancer care, how it's becoming more complex, more technical. How do community hospitals fit in with this? Are you providing, more less acute cancer, more common cancer care in the community, or more services in the community? How do community hospitals kind of fit in with this equation amidst this evolution?
Sure. Well, I'm glad Craig went first to give a really nice summary of the advances over the last 20 years, because I'm sure there's nobody that knows more about it than he does. And I would say that we complement all of what he was talking about beautifully. So much of the research and drug innovation and progress, we're so fortunate that a lot of it's occurring at Dana-Farber and other institutions in Boston that are certainly benefiting our patients and our physicians. What happens in our cancer center is we have top trained oncologists from the top institutions in the country that work here and provide a really personalized care for the patient. So, I think one of the benefits, when you're diagnosed with cancer, the most precious thing is time, and not only time to diagnosis, time to treatment decisions, but also just the time it takes to get to and from treatments. And so what we try to do is shift that as we're providing the same outpatient chemotherapies and treatments. We have a joint venture with Brigham and Dana-Farber for radiation oncology. I think, but the benefit for us and for the vast majority of patients is being able to get that care in the community at which they live. And then we certainly partner with Dana-Farber and others when there is, a subspecialty or a very unique diagnosis, which would benefit from a doctor who sees this much more routinely than we might once a year. So I think there's really good partnership, really good collaboration. But I think, we're able to provide the same chemotherapies, drug therapies at our facilities here in the community that you would get, at Dana-Farber. I would agree. We've also seen a huge shift from inpatient to outpatient, not only on the chemotherapies, but also surgeries. A lot of surgeries 10 and 15 years ago, you would have a 3, 4, 5-day stay for some of the same reasons: pain, risk of infection, et cetera. And now those can be same day. And so again, a lot of those surgeries here at Sturdy, when needed, we have a wonderful breast surgeon and colorectal surgeon and general surgery, urology. So a lot of those care is being done here. And then we complement and work with Dana-Farber and others when needed.
Yeah, can I just want to, I think what Amy says is exactly right. We don't see community hospitals as competition for us. We really see them as partners in our mission. And, in fact, our model of care depends on our partnership with our community hospitals. In addition to our campus in Boston, we have 6 regional campuses around Massachusetts and Southern New Hampshire. And at each of those sites, we work closely with our partner hospitals like Sturdy, trying to keep care local for patients and for those, for those treatments that can be delivered safely. And, it's far better for patients to be able to be treated close to home. They can have surgeries, their imaging, their labs, many of their hospitalizations in the community where they live. And then when there's the need for sort of a different, higher level or more complicated level of care, we can bring those patients into Boston.
Yeah, Craig, I want to stick with you too, because one of the kind of big stories that has happened around cancer care in the last year has been Dana-Farber's announcement of building a cancer-only hospital, and in so doing, moving away from its longstanding relationship with the Brigham and establishing a new relationship with Beth Israel. And so I was hoping you could talk about that project within how you see the future of cancer care. What will this project facilitate? Why did Dana-Farber make this decision, especially as we talk about, care moving increasingly to outpatient, collaboration with community partners? Why is it so essential to establish so many inpatient beds in Boston?
There's a number of factors here. So one is that cancer incidence is increasing. 40% of us are going to develop cancer in our lifetime. The most recent CDC data actually shows that there's been an increase of 11% in the incidence of cancer over the last 4 years. It's higher in Massachusetts, more than double that in Massachusetts. We already, as I said, cancer care, particularly the newer treatments, the more complex therapies, are shifting back into the inpatient setting. We have an aging population, and the biggest risk factor for cancer is age. And we already have a shortage of beds. We have patients who are sitting in emergency rooms, sometimes for days, waiting to get a cancer bed. We have patients at our community partner hospitals who are trying, where those providers are trying to get a patient transferred in, and we have difficulty doing that because of the lack of beds. I think the big issue is that the data show that outcomes are better at dedicated cancer hospitals, and that's what we're planning to build. It's not about increasing the number of cancer beds. In fact, we have more than 200 patients in beds now and housed within the Brigham, and we're collaborating with Beth Israel, who has 100 patients already. So it's not a large increase in cancer beds. But the data show that outcomes are better in dedicated cancer hospitals. And by outcomes, I mean survival. And that's not an opinion, that's data. And it makes sense, really. If all of your physicians are focused on cancer, if all of your beds are being staffed by oncology-trained nurses, if all of your policies and procedures are designed around the care of cancer patients, all of your investments are in the care of cancer patients, in general hospitals, they need to really have policies, procedures, investments in all of the different service lines in their hospitals, in OBGYN, in cardiac surgery, in pediatrics, and so it makes sense that the more you do of something, the more you've invested, the more you see something, the better you are at it. It's like anything else in life. The more you do something, the better you are at it. And multiple other NCI designated comprehensive cancer centers around the country have recognized the trend in cancer incidence and are building cancer beds. And the vast majority of those are in these dedicated cancer hospitals based on these data. So MD Anderson in Houston, University of Chicago, City of Hope in Los Angeles, Mount Sinai in New York, they are all building dedicated cancer hospitals. It just, with Boston being the hub of medical care in the United States, it just, Boston should have one too.
So will care look fundamentally different at this new facility than in the past? I mean, it will certainly be in a new building. Everyone in there will be dedicated to cancer in a new way, but will the patient experience the care in a different way?
I think so, yes. I mean, I think this gives us an opportunity to in many, many ways, to actually envision what the future of cancer care should look like. How can we bring AI? How can we bring robotics? How can we bring, the design of the rooms and the facilities to be something that is more patient-centered, where families can actually be, staying with their loved ones. It's also different in that, again, all of the beds will be staffed by oncology-trained nurses. That means that these are people who understand the diseases, who understand the side effects of the diseases and the side effects of therapy, can recognize those earlier, can intervene earlier, and prevent prevent worse outcomes, improve outcomes for patients and their families. And that, I think, is fundamentally critical. It also increases access, frankly, and that's important for us as well. So I think it really does mean a different future for the cancer patient and their loved ones.
Amy, your health system, as you mentioned, has been investing in cancer care. At the same time, over the last decade or so, you've seen encroachment of other health systems that are trying to and have opened facilities in your market. And so how can community hospitals compete in this increasingly competitive landscape?
Yeah, I mean, first of all, it's hard to think, it's hard, the word compete is hard when we're talking about the care of cancer patients, because it's really, it's, maybe it's hard to use that word, because I think when you talk to our oncologists, myself, when we talk to our patients, we're not competing. We want the best outcome for these patients. If it's my family member, if it's me, I want the best outcome. And I want to mention, we are heavily investing in oncology. And actually, we just broke ground in January on a brand new 60,000 square foot cancer and specialty care building on our hospital campus. It should be open next spring, summer of 2025. And the whole thought around that was, how do we make care seamless and accessible? Craig mentioned, like, we all work so hard when we have a patient with diagnosis. Dana-Farber, I believe, has the same commitment we do of getting that patient in like within 24 hours. But there's so much more coordination that happens, right? When you have this diagnosis, there are specialists, there are surgeons, maybe you're going to start chemotherapy and you need to see a cardiologist first. There's imaging, there's labs. And so what we're trying to do is bring that all together into under one building, because we talked about, like, time is precious, and having to go, and a lot of our patients have transportation issues or mobility issues, or they're taking days off work, or there's all of these complexities that go into a human getting a cancer diagnosis. And so the thought behind the building and the investment in our community in this service is to bring all that care together. So it's one stop for, one parking, one day to come and get your imaging and your labs and see your oncologist and see your surgeon, et cetera. And so that's, really our commitment. I think one of the things that we, talk about is it's important to not have duplicative services. That's when we talk about healthcare costs and the rise. We want to make this as seamless for patients, so you're not being bounced from one facility to another, having duplicate imaging, having duplicate, it's one thing to get a second opinion. And again, our oncologists are continuously working with those at Dana-Farber, whether it's for tumor board or doing their own peer-to-peer second opinion, because we always want to make sure, like, is there a clinical trial? Is there something else that we haven't thought about? And I would say 9.5 times out of 10, the answer is no. And the course of treatment that was prescribed is what's going to continue. So I think, again, we as healthcare facilities need to make sure we're not duplicating services, and that we're not creating, this monopoly, which does drive up costs and everything. But I don't think that's what's occurring. I mean, I think so many of our specialists in the state of Massachusetts are still booked out 6 and 8 months. And so there is such a tremendous need when, we can care for 90% of our patients here at Sturdy in this community, but the 10% that urgently need higher acuity. And I think, there's been many times, especially over the last few years, where there's not a bed available in Boston. And so I think, that for me is where we can work together versus compete.
Nakia, I mean, we just talked about the kind of incredible and growing array of cancer services in the state. I mean, your organization is focused on some of the most fundamental parts of just reaching care, transportation, food in order to provide for your family while you're going through this process. And so are cancer services fundamentally accessible here, or do we even have strides, despite all the array of services? Do we as a state need to do better just helping patients with the most basic aspects of receiving that care?
Yes, and I want to agree with Amy with what she said. I'm speaking from my own experience when my mom was going through cancer treatment, and we lived 30 miles from her facility. And during an emergency, we could go to our local hospital, but they didn't have all of her records. There were times she had to be transferred by ambulance to the facility in Boston because they couldn't care for her because of her specialty. So having community hospitals that have all of your information, all of your records, the equipment to get X-rays, to get scans, whatever is needed, I think we'll have better outcomes. So I just want to agree with Amy with what she said in regards to that, because it is very important. So there is still more that we need to do. Patient navigation is one of the biggest things that I think helps with that. A patient navigator can reach out to a patient even before they're coming to their first appointment and assess their needs. Once you assess their needs, you can provide services and they know they're all set before they even get to their first appointment. So that's one less thing that they have to worry about. When someone is getting a diagnosis, a lot of things are coming at them at once. And it'd be nice if every hospital, if every community hospital, major hospitals have dedicated patient navigation so that patients can feel that they're being heard. Doctors are into treatment. I'm not saying all doctors ignore patients, but they have a lot of patients to care for. So if there's a dedicated person who can guide patients through the journey, understanding what their diagnosis means, it will have much better outcomes.
Yeah. I want to talk about cost. Some of you brought up the idea of cost. Amy, I mean, community hospitals, one of the main things that people talk about is the value proposition. And so does that extend to cancer as well? Like, is the role of community hospitals within cancer care, not just local accessible care, but more affordable care?
Yeah, I think so. I mean, there's study after study that shows cancer is one of the most expensive medical conditions to treat in the United States. And that, there was an article in January that came out that said, a cancer survivor indicates that they spend more than 20% of their annual income on the treatment. And that's just not copays and things like that, but it's also, again, transportation, lost work, et cetera. So again, first of all, it's probably a whole session on the cost and the financial toxicity of cancer. But I think at some point we should also talk about the absolute need for a focus on screening and early detection and prevention, because that not only does that dovetail into survival, survivor and all of that, but it's also decreasing the healthcare costs. I think in community hospitals, I mean, I think about it like at a very basic level. The cost of living in Attleboro is less than Boston, right? I mean, our housing costs, right? The rent or lease that we pay on our buildings is less than it is in downtown Boston. And so there is some inherent expenses that are less than a facility in Boston. At the same time, and Craig could talk about this more, we also don't have, the research and the academic components, which there's that is an expense, but also, again, we are the beneficiaries of that research and that innovation. And so I think it's, there's a place for both of us, right? That there's a place for the lower, cost system. But again, part of that is because of our actual physical location. I think what we all need to collectively do is make sure there's not duplicate testing, that we can create, care in this in one facility. So a patient's having to come to Attleboro or Boston once, not 5 times, right? All of those things add up when you're taking time off work, when you're dealing with transportation. Maybe we're going to talk about it in the equity section, but we have a large percentage of patients that literally walk to their appointments, or are taking public transportation, or relying on Uber, and we're providing vouchers and things like that. And so I think, that's where the financial burden, and there's another, survey that just came out that says in Massachusetts, 50% of adults are delaying necessary care. And, and again, all of that ends up being, in the pandemic, we were doing so good. Again, I feel like Craig has more of the stats than I might, but we were doing really well in really making advances in screenings and early detection. And then the pandemic, we saw a lot of delayed care. And so now we're seeing the outcome of that. And that just equals a higher cost care when you are having to be in the hospital, when you are requiring later stage disease treatment.
I think, Amy has made a number of really important points. So I think in addition to it being more convenient for patients, care at the community hospitals is frequently less expensive than at the academic medical centers. And And that's another advantage of the community model that we have, so that patients can get the appropriate care close to home and frequently at a lower cost, by way of our partner hospitals for services that can be delivered in their communities. Academic medical centers are more expensive. They have a different infrastructure, infrastructure requirements to be able to perform the more complicated treatments, to provide the care and services that can't be delivered in the community. And that infrastructure costs more. So, I think the model of partnering, that's like, none of the three of us are coming at this like, in competition or opposed to each other. We're all on the same page that, partnering for what can be done in the community to provide those specialized services in the community. I mean, one of the things we've done is we've built a really robust infrastructure in the community to be able to offer clinical trials to patients closer to home rather than having them have to come into Boston. So we offer literally hundreds of clinical trials to patients at the community in the areas that we partner with. And being able to provide that there and being able to provide the more complicated care in Boston, I think is the most cost-effective approach.
Craig, I also want to ask you from a physician perspective, how can doctors confront the issue of cost in the midst of treatment? I mean, I understand that it's, they're there to provide the medical care and the medical expertise, but how can they or should they help the patient navigate this? Is it their responsibility? Do we need to bring more people involved? Like, what's the role of the physician in this cost?
Yeah, so costs of healthcare and particularly cancer care is complicated, and it's difficult for any single group to control the cost of care. Doctors, hospitals, pharmaceutical companies, but we all, I think, share the responsibility to try. There are ways that physicians, I think, can help to address cost. One of the things that we did at the Farber was, a major source of cost is the emergency room for cancer patients. And it's not just the emergency room. It turns out if you're a cancer patient and you end up in an emergency room with a complication from your disease or from your treatment, there's an 80% chance you're going to get admitted to the hospital. And both that ER visit and the subsequent hospitalization are extremely costly. And one of the worst experience, and I'm looking at Nakia, one of the worst experiences that a cancer patient has. And several years ago, when we looked at the reasons for admission, we estimated that a significant number of those admissions probably weren't necessary if someone who was familiar with the disease and the treatments was evaluating the patient rather than, an emergency room physician. And we could intervene in those settings. And we established an acute care clinic staffed by people who knew the diseases, knew the treatments, knew the potential side effects and complications. And that meant we could better identify when someone truly needed admission. And often we can intervene to fix the problem and avoid that admission. And what we found was that we decreased emergency room visits by 20%. And of those patients who we saw, instead of 80% of them being admitted, 80% of them went home after they're sort of, receiving some care in the clinic. And it improved the patient experience because it's much nicer for them to be seeing someone sort of quicker and not be in a big emergency room where cancer patients are both afraid because there's lots of sick people in emergency rooms, but to sort of be seen quicker and to be able to go home. So that's one way. There are others that we've done in implementing clinical pathways that we've created that help to make decisions that are most effective therapy, least toxic therapy, most cost-effective therapies. And in these pathways that our physicians have created based on the most recent data, we've published data to show that, in stage 4 lung cancer, we reduced the cost of care by 22% through the use of pathways. So there are things that doctors can do to intervene. I think the other thing that, Nakia points out is really the incredible need for navigation and you know, for you know, for helping people who, you know, we have partnered with federally qualified health centers. We've created an ambulatory safety net and worked with organizations like Nikia's, but like the Ellie Fund, to, you know, identify social determinants of health, particularly in patients who have been historically marginalized, to have both lay navigators and resource specialists for them, and nurse navigators to help them through their treatment, to be able to access the care that they need, to be able to get them into clinical trials that are in their communities, or arrange the transportation, or the address food insecurity, things like that. Those are not things that are reimbursed. They are, you know, they are funded either through partnerships with organizations like the Ellie Fund, or funded through philanthropy, or funded through, you know, through our other, you know, other resources that the hospitals provide. And those are things that actually, you know, payers can participate in as well. And in fact, there's a group of folks, including payers, looking at how to do that together.
That's fascinating, and leads me right into my next question for Nikia. You know, the costs of cancer care go beyond just the medical costs, and your organization helps with a lot of those things. But is it enough for organizations like yours to be doing this work? Do insurers and providers need to put money toward the food, the transportation? I mean, correct me if I'm wrong, but a lot of your funding is philanthropic, right? Or are you getting
Correct.
support from? So does more need to be done to shore up the financial resources to ensure the things that you're providing are able to be given?
Yes, I would agree with that. And there's always going to be cost with cancer. No matter what we do, there's going to be cost. Um, a lot of patients have these determinants before they even get a diagnosis. Things are needed: childcare, food, gas, transportation, Uber or Lyft. Like, the one thing we would hate is for a patient who is going through chemotherapy treatment to get on a bus or a train to get to their treatment. If we had more money, we could give more. We're trying to grow our patients, but we can't do it alone. We need the help of partnering with hospitals, partnering with other organizations, so that we're only limited to what we can provide on either a 3-month or a 6-month basis. But a lot of times patients are in treatment for 2 years. So yes, we can help them in the beginning, but we're not always able to see it through. So we need more partnerships so that we can ensure patients go to treatment, because as stated earlier, patients will not go to treatment if they don't know where they're going to send their children, or if they don't have food on the table and they need to work.
Mm. I want to also talk about equity. And Nikia, your organization is need blind, and I also learned yesterday it doesn't have a citizenship requirement. And I was curious why those things were important. Like, has it furthered the equity that people don't have to worry about filling out forms and looking up their latest tax information? Is that a challenge for delivering equity because you don't fundamentally know the needs of your patients? Like, how have you come to that decision not to be need blind?
Through our patients. Our patients are so grateful that we don't have to ask those questions. They don't have to fill out. That's another thing, to fill out several forms to prove. We don't care. We're just looking to help a patient, whether they're not making any money or they're making thousands of dollars. If you have that, those are barriers. A patient won't fill out something if they feel like, oh, if I put my income, I'm not gonna get a grant. Or if I put that I'm not a citizen, I'm not going to receive a grant. So we're eliminating those barriers. So all they know is, whatever I do, I'm going to receive a grant, and there's no barriers to their care.
Mm. Craig, how is Dana-Farber ensuring that the patients that it cares for come from a large range of needs and equity? Like, how are you ensuring equity from a institutional perspective?
Yeah.
Particularly, like, there's you know, people have insurance that dictates where they go, and so I don't know if Dana-Farber takes all insurance, but if not, how are you kind of propelling equity in spite of that, or how are you ensuring equity overall?
Yeah, no, it's so it's a very important question. I think in healthcare in general, we face the same challenges of equity that every other area of society does. Socioeconomic, racial, language, education, and we firmly believe that the quality of care that a patient receives, that the care options and their treatments shouldn't depend on your zip code or your race or your gender or your sexual orientation or your ability to speak English. And so we've done a number of things. So as I mentioned, we partner with federally qualified health centers to provide services in those centers and to provide this ambulatory safety net of lay navigators and resource specialists and nurse navigators for screening, and if patients are suspected to have or diagnosed to have cancer, to bring them to help navigate them into our system. We have mammography vans that go out into communities to provide mammography, prostate education, skin checks, and skin cancer education in these different communities. We have built partnerships with, as I mentioned, other organizations like the Ellie Fund and others to address needs like food insecurity and transportation. We have built this robust infrastructure of clinical trials that I mentioned, and we partner with Boston Medical Center and other centers that actually help to take care of historically marginalized communities as well. And so, and then I think, it should also be mentioned that I think just opening your doors to people is not enough. You need to demonstrate to them that you are really there for them. And one of the ways to have people feel comfortable is if there are people who share the same culture and share the same history and who look like them. And we've developed a number of programs to residency programs to try and increase the diversity of our workforce, of our nurses, of our physicians, of our clinic assistants, so there's a tremendous amount of community outreach to try and do this. From a insurance perspective, we actually believe that the changes that we're making with the building of the new hospital are going to improve that, because our current partner is a member of MGB. MGB does have significantly higher rates, and that can sometimes be a problem for patients with respect to insurance. We anticipate that the cost of care is going to drop significantly. The cost of our inpatient care for our inpatient beds is actually less for cancer care. The same, and our new partner, Beth Israel, is also less. So we anticipate that the cost of cancer care is actually going to decrease, which will actually then improve the outlook for payers to allow their subscribers to be able to access that care. So we think that the changes will actually improve access for patients.
Amy, I appreciate that so much of the social determinants of health, are outside the bounds of what a hospital typically delivers. And so how is an organization like yours grappling with things like food and transportation to ensure that care is delivered equitably, in particular cancer care?
Yeah, I think what we've learned is that it is maybe historically it's not been the role of a hospital or health system, or maybe we don't get reimbursed for it, but it is what matters. And it is what differentiates a patient's outcome. And so I don't want to duplicate what my colleagues just said, but we are also partnering with FQHCs. We partner with the YMCA, we partner with the Ellie Fund and other organizations, the Andrewsy Fund, et cetera, Andrewsy Foundation, to make sure we're providing comprehensive care. So we are constantly focused on transportation and food. We partner with community servings. They're just, I think next week, groundbreaking in Mansfield. And I would say that for us, it's also really focusing on access to care, because, and I mentioned it a couple of times and I sound like a broken record, but so much of this can be dealt with much earlier stage if we have access to primary care, if patients have equitable, easy access to see a primary care physician, who they relate to, who they connect with, who can then ensure that they get mammogram, lung screening, skin screening, whatever all the different preventions or screenings that we can do. You know, we have a high risk clinic. Like it's not bringing in revenue, but it's so important for us to identify early on and do that high risk identification and the education and the prevention. And it's like it's the stuff that matters when we talk about nutrition and exercise and emotional support and all of that. But it's the stuff that gets overlooked until you end up in the emergency room, and then you're found with late state disease. And then the whole treatment begins at a much higher cost, higher acuity, emergency level status, versus if we could really focus on that equitable care much more further downstream. So we partner with Manet and many of those other, Manet's a community health center, and within our own primary care centers, trying to continue to expand access to primary care, but also access to screening. So we do multiple different community events where you can pop in and get a skin check, or again, you can come get your mammogram on a Sunday night, or whatever the different things are, to make sure we're making it as accessible as possible for as many people as possible.
We are running out of time. I have so many more questions to ask all of you, but I'm going to ask some of the audience questions. Craig, maybe you can take this, but someone asked what types of cancers are pushing the incidence of cancers in Massachusetts. Can you talk a bit more about what we're seeing locally?
Yeah, we are seeing increases. We're seeing increases in a number of cancers across the board. For women, breast cancer, colorectal cancer. We've seen nationally a significant rise in colorectal cancer. And somewhat shockingly and scarily, we've seen an increase in cancers in people less than 50. So that, and a much steeper increase in incidence in younger patients, such that colorectal cancer is now the #1 cancer in men less than 50, the #2 cancer in women less than 50. So it's, there's not a good breakdown for like all the different cancers in Massachusetts, but we're seeing an increase, and we've been seeing an increase in these cancers by about 1% a year since the early 1990s. And so, and it's estimated that we're going to see an increase of about 50% by 2050.
Wow.
So it's, you know, the tsunami is coming, and we need to be prepared. And we need to be putting our efforts into how to mitigate it and how to prevent it.
Yeah. And so Nakia, I mean, it ties into another audience question here, which is, how can cancer survivors help others going through the experience? Like what kind of volunteer opportunities, fundraising, outreach is available? I mean, through your organization specifically, how can people, if a tsunami is coming, what can people do?
Yes, we always, sorry, I'm not moving enough, so my light's going in and out. Um, thank you. So we're always looking for volunteers. We are a small staff. We do a lot. We're mighty, but we need help with distributing gift cards. I started off volunteering. So I was a patient of the Ellie Fund, and then I volunteered because you want to give back. You feel grateful for what you received, and you want to give back, and spreading the word. That's one thing you can do without anyone telling you, just spreading the word of what we can provide, what's out there, educating others. I'm always a person people reach out to, even if it doesn't have to do with breast cancer, but any kind of cancer that has to do with screening. So be available for people who have questions. I think that's the biggest thing that anyone can do, and you don't really need much knowledge of it to do it.
One question for all of you, and we're running out of time, so I'm going to ask you to do it in a sentence if you can. But if you could, I've been doing this lately where I ask people to like manifest what the future looks like. If you had your way, if there were no hurdles, if there were no financial challenges, 10 years from now, describe your vision of what quality, the ideal cancer care would look like. Craig, let's start with you.
If all goes well, I would say if all goes well, the Dana-Farber will continue to partner with our community hospitals to provide great cancer care in patients' communities, and will have New England's only dedicated cancer hospital providing state-of-the-art care in a state-of-the-art hospital, continuing to advance the diagnosis, treatment, cure, and ultimately prevention of cancer, so that my children's children and yours read about it in the history books.
Thank you. Amy?
Yeah, I would say I hope that we have excellent access to primary care, that every human is getting the appropriate screening and early detection, and that I think the trends in cancer care are going to continue to be, you know, drug innovation, the precision care, AI, even in detection and screening. I think we'll be able to do like body scans that are not invasive and use AI technology, et cetera. And I would echo what Craig said. I hope in 10 years, we're talking about truly like curative care, and that somebody with metastatic cancer, like we're talking about them being cured. And I also hope that my children and grandchildren are reading about cancer in the history book. So
And
great
Nikki?
goal.
And now I have to top that. I would say it would be a service like the Ellie Fund would be an opt-out and not an opt-in. You would be able to just opt out if you didn't want it. You didn't have to be asked for it. It would already be there. And that we have more innovation with technology, so that there are better outcomes, and that more people are educated and know their bodies and know when to reach out to their primary care, so that things can be addressed in the beginning rather than in the late stages.
Excellent. Well, I'm hoping that we don't take a decade to get to some of those things. They seem entirely achievable in the near term. I greatly appreciate all of your time, expertise, and energies toward this effort. And thank you all for joining me today.
Thank
Thank
you.
You.
It's a pleasure.